we have for the oration. Sunita, there was some lady coming out in Pune side in many years back for endoscopy. Wondering who is this Sunita Tendulkar? Is it like Sachin Tendulkar's cousin, or what is exactly this lady? Let me check on her whether Sachin makes more runs or whether she makes more scopies. And ultimately, she blossomed into a queen of endoscopy in Pune. And this is Sunita Tendulkar. She has got a very extensive biodata, and I've gone through it. She's in the Ruby Hall Clinic, the charge of that clinic in Pune, which is the best clinic owned by Parsis. Then there's a solo clinic when she has stem cells and IVF and everything else which you can do in IVF and ART. I don't know what she's left out. And in association also, she's the president of IAGE. She is in the ISAR. She is the Maharashtra chapter chairperson. She is a second vice president of ISAR. And you can go on endlessly. And what I would like to do is today's talk of hers, which is me in endoscopy, a love affair. That interested me, that though she's an excellent endoscopist, ART specialist, and the way she's handled the last year of the presidency of the IAGE, she was a people's person and she led from the front and gave equal chance to everybody to blossom. But this topic she's chosen today, which is a love affair, it made my tentacles a little sharper. And I think I'm going to introduce her topic and her with a little song sung by Elvis Presley called Love Me Tender, but I'm going to make it Love Me Scopy. Sunita, here goes. Love me Scopy, love me sweet, never let me go. You have made my life complete, and I love you so. Love me Scopy, love me true, all my dreams fulfill. For my Scopy, I love you, and I always will. Dun, 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 dun. Sunita, the stage is yours, the guitar is yours, the piano is yours. So go and paint your picture of you and endoscopy, your love affair. You're all waiting to see it.
Adi, you know what? I need to thank Kumar for one more thing.
Yes.
This oration I get because I'm outgoing president. But selection of a chairperson was Kumar's job. And I don't think I have given numerous oration, but such a beautiful chairperson I got, a golden-hearted guy who is creative. So today I'm fully blessed. This oration will be remembered not for the orator, it will be remembered for the chairperson.
No, for the orator. You see now what you talk, it will be fantastic.
I'm sorry for not allowing your video because we wanted Dastur to talk.
I know that.
Sorry.
I know that.
Sorry for that.
Thank you. Thank you for that. And now let me start with my oration.
Love affair.
Me and endoscopy, a love affair. It's an absolutely red color. It's blowing from my heart. Friends, I want every morning to start being wrapped in your arms. That's what I tell endoscopies. Dr. Grant asked me, Sunita, how would you love to die? Where? I said, in the endoscopy operation theater while performing with the great endoscopic surgeon as an assistant. He said, why? I said, after I collapse, he has to take over the surgery further. So my love affair, whether it was for a first sight or was it a thought process over a period of time, I don't have the answer for it. My true love affair began the day I heard news of Harry Ridge performing the first laparoscopic hysterectomy in 1989 when I completed my MD, and I was not knowing. I don't wanted to do the lecturer post and all, because during residency, hundreds and thousands of Caesars and hysterectomy we did. And this was, I thought, oh, I knew only vaginal way and abdominal way. And what is he talking about laparoscopy? And that opened my eyes, my ears. My real love started when I began my practice way back in 1992 with level 1 and level 2 laparoscopic surgery. And it blossomed, my love blossomed to level 4 as the time passed on. I came to this city. I don't belong to Pune, but now I love it. It's my Ajna of Gagangiri Maharaj who said, you just are going to go to Pune. I had only 1,000 rupees in my pocket. We all who are from that generations know that we earn 400 and 1,000 rupees as a residency fee. So we had only 1,000 rupees and I came into this new city. But I wanted this dream, dare to be different. This was very important. And don't become the subject of criticism for others in a new city with new technology. And only two ways it will happen if I don't land up in complication. So improve every day by watching your own videos and shorten your learning curve. It was the days of a VCR, and in the night I used to watch my own video and used to ask myself in what way I would have performed better. And second important thing was, don't land up into any litigations which will spoil the name of endoscopy and the name of mine. I was very fortunate. Dr. Rajesh, my husband, the partner, the backbone, he was my support system because he was himself a fantastic laparoscopic surgeon. So I never needed that I need a partner. My love and passion for endoscopy has taken me to the position today desired by many as the head of Ruby Hall IVF endoscopy department, as head of OBGY department. I have a lovely platform to perform. What I am today, I give a credit all to Ruby Hall. Dr. Grant in 95 called me, join the hospital. And I was wondering, why do I join when I was happy where I was performing at Pune Hospital? And he said, I have heard you doing laparoscopy and I want you to join. Now, sometimes you need to be blessed at right time, at right place. And then there was no looking back. It is all because of relentless hard work, strong ethics, genuine honesty, and countless blessings. I decided one thing: I'm not going to leave the ethics of my practice, because that is where it will take me ahead when I look back 25 years, that how I achieved this. And you need to be very honest with every patient and honesty with your profession. There is no elevator to success. I don't want it to reach at the top on a day one. You have to take the stairs 1 year every day. When I came to Pune in 92, there were no institute who had laparoscope. So the first thing was, I have to take a loan and buy a single chip camera. And I don't wanted to buy that VET-K or VATEC, some 20,000 camera. It was a LEM-K camera, which was little expensive, of some 2 lakhs rupees. And I have to take a loan. Till today, I have it in my cupboard. And then I gathered the money to attend an international conference held by Anuvates, where he showed TLH and Birch. And then there was no looking back. Just attending that laparoscopic conference, I came back and I started in 94, 95 my surgeries. Love understands love. It needs no talk. And that's what endoscopy was. Endoscopy also loved me and allowed me to grow. What did endoscopy do with me and my career and my profession? First thing is, it gave me the greatest gift, recognition as a surgeon. It started as a little seed and has grown into the flowering tree. It was very, very important. We all know that as an endoscopic surgeon, we often face the challenges and we need to master them from time to time. In endoscopy, we have two types of challenges. One is, on one way, the technologies are advanced and you need to master them from single chip to three chip to HD to 3D to robotic. Energy sources from simple monopolar, bipolar to various advanced energy sources. You need to have a thorough knowledge and the physics of understanding of it. And the challenges are also with the patients, their pathology itself, or sometimes their fertility option to be preserved and all. We don't grow when the things are easy. We grow when we face the challenges. And I thank my each and every challenging patient because they shaped me as endoscopic surgeon. So I say, don't limit your challenges, challenge your limits, challenge your mind. Each day you must strive for constant, never-ending improvement. Endoscopy is not like an open surgery. You need to practice to master this art of endoscopy because first of all, it is a surgery of instruments. So you need to learn them. When I started hysterectomy, there were no manipulators. And when I watched my own LAVH, I realized I want to have apparent learning of all ligaments. And for that, I need a manipulator. Being we all in government colleges, we are great vaginal surgeons in India. And I always felt if I can't complete laparoscopically, I can do vaginally, but I need to use a vaginal hand. And first thing I did is design my own manipulator. I wanted serration so that it will not perforate. I wanted the curve so that it can move the uterus very well and gives me apparent lengthening. I wanted different type of rings so that I can elevate any type of vagina, whether small or large, depending upon how the fornices are. Second challenge happens in endoscopy is two-dimensional. In open surgery, we are so used to three-dimensional. So two-dimensional vision, one thing, there is no depth of perception. And second, you need eye, hand, and leg coordination. Your eyes on monitor, hands holding the machineries, and leg helping or working on various energy sources. So you need a coordination, and that's why I said you need a practice. Today, we are in a beautiful world of
Gynecologists see very much
we
the
don't have to
ease with she works
worry
with all.
about it. Why? Because now we have evolved with the technology. But when we started in 94 with the single chip camera, believe me, today I feel how I used to work with the three chip cameras. The clarity was so bad. And now when you work with 3D, it is fantastic. Robotic came in. With every improvement, my love kept on growing. I am not here to put the controversy whether 3D is better or robotic is better. It depends upon the situation. It depends upon the pathology you are handling. What is important is you learn that technology. Again, being very fortunate in Ruby Hall, where every technology comes in India, it is absolutely taken in there. And I
Leader
love
and innovator in minimally invasive laparoscopic surgery and specializes in robotic procedures. She enjoys being at the console. She feels robotic surgery is a different ballgame altogether.
you know what? The robotic surgery is so simple to perform. What was important for all of us to understand is they are very disciplined. Unless you take a training, you are not allowed to sit. I wish this can happen with laparoscopy also. The training, you have to undergo extensive 1-day program with them. And then what I did was I sat with tomato in the evening in my robotic OT. I used to make emergency sister sit with that tomato, and I made a practice of peeling the tomato skin. And then once I peel it, I used to resuture. I realized 3 days of my practice as
Leader
3 days of my practice, and it helped me to optimize my skill beautifully. Now it is up to you to decide which surgeries you choose on to robotic and which surgeries you should be choosing on to do with the 3D laparoscopy. Whether as a benign surgeon for a routine hysterectomies and myomectomies I would like to do is personal choice. But certain surgeries like microsurgeries, tubal microsurgeries, pelvic floor deep, oncological surgeries, yes, definitely there are certain advantages. What I did was peeling off the tomato skin and resuturing, because I believe that if you learn resuturing, nothing is important. Suturing scale is the must for you to do any surgery, and that's what when I chosen for the first surgery as a tuboplasty, I realized that anesthetist said 4 घंटे का अभी काम है, सुनीता काउंसिल से छोड़ेगी नहीं, but we will allow you only one tube. And we realized that in 40-45 minutes, I finished the tube. I told them, if I finish in 45 minutes, you design 2 hours, 3 hours for me. I'm going to do bilateral. Let me do the practice. It's not for my practice. I don't know which sided tube will work. And I need to give a justice. I need this patient to conceive naturally. Now today, the baby is more than 1.5 years old. She was my first laparoscopy, robotic surgery. And believe me, robotic surgery is much simpler than laparoscopic surgery. Your all instruments, they move with 560 degrees. So it's so simple. You don't have to. Then the camera control is in your hand. So you don't have to keep on telling your new fellows, come close, come close, come close. Especially the male fellows who will say, "Aur kitna close aao, ma'am." So fun apart, laparoscopy, robotic, they all have their own advantages. Today, how we feel it is criminal to do open surgery for ectopic, similar way, the day will come when microsurgery, the most important thing is the cost involved in this. And that is why in India, I can afford to have a good laparoscopic surgeon as a helping hand than such a expensive and machineries. I do believe that. But since my institute has it, it's important, I use it. Now, another most important thing I would like to say is selection of cases. You don't want laparoscopy to be blamed, then your selection of cases in early part should be very, very clear. Every surgeon should pick up the right surgical technique for the right patient, understanding his and her limitation, and must over the subject. Because Dr. Kumar can do doesn't mean you can do on day one of you. Remember, as your experience increases, your exclusion criteria relaxes considerably and you can proceed for more complicated cases. It may be 140 kg patient or it may be big fibroids. How big should be big is your decision. You can't ask the others. You have to decide how big should be big. Don't take such cases. I have never operated in 95 and 96 with such a large myomas as the time passes on. But when you go in laparoscopically determined, one thing is important. You take a consent of open surgery also. Don't be overconfident. And second thing is go inside with determined mind. Okay, I'm going to do it. So keep sufficient time. Don't bump up with so many cases on the same day. I usually love to use bipolar vessel sealing and then I cut because I believe in having a bloodless surgery. I just love it. I feel all the team member enjoy when it is bloodless. Only problem is reaching to the lower pelvis because your all instruments are up. You can keep on taking more pores, but that's okay. What is important is to do it successfully. In such cases, the skill is not the surgery. How to retrieve the specimen is the most important. You will see it was absolutely bloodless, but keeping the preparation of open. Believe in chasing excellence every day. You can't say, oh, last 2.5 decades I'm too good. No, you can land up in complication and then you cannot say, oh, only one complication in 5 years. For that patient, it was 100% complication and she did not come to you for complication. So to excel your performance, what is important is your pre-operative procedure, absolute discipline. Success is nothing but the discipline observed every day. Prepare yourself well before each surgery to excel. I don't like surprises in the camera. So I don't just plan the surgery patient आया पूरा surgery का pre-plan somewhere else and says I'm fit, plan it tomorrow. I never do it. Apart from pre-operative fitness, I like my anesthetist to see the patient. It's a mandatory for me. I establish my own diagnosis. That's what I said. Don't like surprises. Whole India knows about the excellent sonologist I have it. I explain patient myself, surgical and not surgical procedures. What are the pros and cons? Whether I do surgery, if what will be the complication that can happen, or if you need a surgery, what are the alternative method? I can't have a patient coming back, oh my God, you did a fibroid, someone told me I can take a GnRH and I can make fibroid disappear. I can't allow that. So I explain the patient what is the need. Also, this is very important. I explain myself to them. Why this is important? Because I enter in the operation theater. I enter in the operation theater when my patient is under anesthesia pen ready. So my chance to talk to them is only in OPD, and I make audio video consent. Fitness and talking with the anesthetist is very important. I'm sorry for the voice. Any important surgery where I want to give deep head blow or I'm going to be London, I discuss with my anesthetist how I don't like surprises in camera. I don't like anesthetist to know 1 day prior that, oh my God, this patient is so high risk, he needs it and this and that. I don't like them advising me any investigation or any cross references 1 day prior because patient gets a shock. Oh my God, मेरा pulmonary function test हुआ नहीं था and they have posted me that shows inefficiency in your part. Laparoscopy is a surgery of a team. Patient, assistant, anesthetist, your ward sisters, ward boys, they are permanently with you and you need to develop the team efforts, then you can perform it more peacefully. Everyone is geared up for that surgery. Intraoperatively, very important. Sometimes if you feel there is a need to discuss with your oncosurgeon, they want to do differently, you do discuss. But you reconfirm your preoperative finding. For example, this patient had 3 important myomas which were to be taken out. I was knowing this is a previous surgery, fibroid multiple, endometriosis, multiple removal, and I had to go for a frozen embryo transfer. Unless I tackle this fibroid, I cannot. What is important is you expected that there are going to be adhesions and you were knowing it. So you were absolutely with the confident mind, you go in and you perform. There was no pressure of performing many more surgeries one after the other. I work in an institute. I can't have next surgeon also sitting on my head. It's important to block the operation theater. All these small things are important. When you enter in, you are aware that you will not be even able to see the fibroid. There was an associated hydrosulfins. Unless I can see only femoral end, but unless I remove this hydrosulfin, I'm not going to give a success for my frozen embryo transfer. Now, when you have a plastered pelvis, it's very important that you keep the ureters and all out. So you go to the lateral pelvic wall. Now, only because you know that how to enter there and how to ligate doesn't mean you should do it. The fibroids were small. My aim to go here was just to identify whether ureter is pulled up medially or if it is laterally. It is laterally, fantastic. It's not coming in my way. I'm not jeopardizing patient. I don't want to complicate by doing a ureteric injury when she has come. And now I can see the fibroids. That's fantastic. Doing a surgery is a simple job, one after the other. It was exhaustive to do the dissection or adhesiolysis. Now, when anteriorly, only my sonologist told me, you will have a huge broad ligament fibroid. It was not obvious, but I knew unless I remove it, I cannot be successful. So it's very important that you do it, making your anatomy normal before. Now, that was a case of a fibroid. Similar adhesions will be there in endometriosis. I think yesterday, Sanjay Patel has done amazing, not only yesterday, years over years, months over months, Conferences over conferences, he kept on teaching the whole India and abroad how to do the endometriosis. And I am sure everyone performs it beautifully. What I believe is using sometimes scissors as an energy source. Small, simple nicks, fiber by fiber dissection, because you have done a good bowel preparation, and the smaller intestine can be just by pushed, compressed, they look like a peritoneal fold. Don't go too much inside, you will cause extra peritoneal extravasation, posterior sheath will come in. Anatomical landmarks will help us to find out. This is what I'm saying. This small intestine, if you see it, they get collapsed, and then you need to understand, you see beautifully the planes opens up. It is just the first nick, and then everything is very good, very clean. I may not use harmonic all the time. It depends upon what case I'm working with. And when I go lower down in the pelvis, I can't even find the uterus. So as usual, from left paracolic area, you go in and you start working on that. What is important in laparoscopic surgery is you need to be by-handed. And if you have an excellent assistant, you become four-handed. If it was a hysterectomy, your fifth person is having his hand in vagina with the manipulator, you become five-handed surgeon. Take advantage of it and keep on doing a dissection from identifiable tissue to non-identifiable tissue. Whether you will go to the lateral pelvic wall, whether you will go into the central, whether you will do pararectal dissection first, all depends upon how the pathology and how the adhesions are inside. Only when you make these, so even if you have decided that I will be going, because I'm getting a plane, I will be just dissecting it beautifully and I'm taking out. This patient had a hysterectomy. She was a previous to cesarean IVF conceived. I was aware with my sonologist saying loops of bowels completely cover the uterus. So first thing is you understood that lateral pelvic wall is easy. I have a peritoneal fluid collection there, blackish. I can see it popping out. Probably the posterior thing is easy. I need to make the bladder completely out so that I can move it fantastically. So this is how you keep on taking small nicks and dissect out the plates. And once you made the bladder down and just moving little forward, and then you go for a uterine artery's origin, and then you proceed for the rest of the hysterectomy. Bladder dissection is just the harmonic, does its own job. Go to the right side. So I always say doing hysterectomy or performing hysterectomy is simple. 3 pedicles on left side, 3 pedicles on right side. Adhesiolysis, making anatomy normal, is the most important step. Very careful use of energy source. That is what is important. Harmonic, I always say to all the fellows, first energy source you buy is a bipolar. Don't compromise. That is going to be with you lifelong. So spend whatever money you have in an excellent bipolar. Nowadays you have a bipolar vessel sealing. You need to have that. Then the second most important thing, especially when you want to do the level 3, level 4 surgery, is a harmonic. All other instruments, you can go without it to level 4 surgery. So you wisely select which are the instruments you will be using it. I'm just showing you how harmonic makes life simple. Huge broad ligament fibroid. Patient comes with the acute pain. She is for embryo transfer. You have to do the ureteric stenting to relieve her ureteric compression. But unless you do this fibroid out, you cannot be. So this simple harmonic, making you enter into the plane, giving your own plane with its cavitating effect makes life simple, and you can perform the bloodless surgery. I sometimes feel that large myomas are more simple. Such myomas, there is nothing great in it. Only thing is entering in the right plane with the right instrument. Your understanding of the anatomy. I'm not going to go for the uterine artery ligation at its plane. Here, in this case, I know that it is a simple broad ligament myoma. I probably remain in a good plane, and once I achieve that, traction and counter traction is better than reaching to the lateral pelvic wall. But if If it would have been a true broad ligament, I might have worked differently. So you decide. You need to have your own skills of a surgery, and then you decide how you should. But harmonic makes life so beautiful and so simple and so bloodless. Now, sometimes look at these three fibroid compressing the cavity beautifully, all the side. Now here, what is important is your preoperative mapping. These are very small, medium size, but they are causing compression. And harmonics allows you to do intracapsular myomectomy. I believe in doing intracapsular myomectomy in all infertile patients. Another important thing is you do suturing after removal of myoma immediately. One myoma out, suture it out, because you have given vasopressin, its action is only for 20 minutes. You don't want those capillary oozing coming out. By VLOG, this has made our life simple. But whenever you are using VLOG, you ensure that you take a baseball. You don't just take a simple or a mattress suture, because you will invite adhesion. This patient, if would not have been for the embryo transfer, wants to go for a natural conception. Her fertility is good, reserve is good, her semen is good. Why not? I will allow her to consume naturally. And there, your post-operative results matter. Now, once I remove the two myomas and I have not entered in, I think Kumar has explained it very well, that Asherman is many a time iatrogenic. In such myomas also, if I open the cavity from all sides and I have to suture it, I will definitely have an intrauterine adhesion. And I don't want patient to land up in any more surgery after my surgery. These are deep intramural. Only your preoperative diagnosis of precise location of it allows you to enter in a right plane. Another way of harmonic is Birch Kalpo suspension. Entering into the lateral pelvic spaces, you have seen ample. Now, these retropubic spaces, they are highly vascular. So, entering into the right plane makes it absolutely avascular. I always go first in 3 minutes to this white, beautiful bone. I need to love and see, and then this white line. Then my job is over on the right side. Preoperatively, you confirm that she has associated defect. Now here, your height matters. I like to put my own hand into the vagina, then remove it and take a very good bite. This is very important. Don't take a fibromuscular, just the superficial tissue. Ethibond makes life simple, but what is important is elevation up to certain level. And here, your assistant holding the knot, and just the vaginal person now putting the finger and lifting and not allowing. Why you should have your own finger? Because you should know how much in a depth you want to take. I don't want to take only this fibrofatty tissue. I want to take vaginal musculature along with the fascia, but not the serosal mucosal wall of the vagina. Very important to take this, and this is the only time I come with the central suprapubic, which we keep on watching Dr. Paul using very frequently. I use it only so that my endosuturing becomes easy. But harmonics is the one which makes the life so simple. Very important, always close. Make the anatomy back to normal. I know people saying, don't close the peritoneum. I don't like it. You don't want the bowel to go and stuck over this. Give back what patient wants. Being in an institute, you have endoscopic GI surgeon, endoscopic urosurgeon. Everyone demands differently. I demand differently. So you landed having RB bipolar, you have ligashire, you have NSEAL. So learn the technology, and just for a demonstration, keep on using. I'm going to show you it's not only that, it's even the monopolar. If you know precisely how beautifully you can decide the depth of a cut, then you can remain beautifully intracapsularly. Make the myoma naked. is the most important. How you take that out, whether you use monopolar, harmonic, gyrus, all is your choice. Here, my radiologist tells me it's a longitudinal. So I'll take a small bite, but I ensure that I will not open the cavity. This is important. Whether single layer closure, 2-layer closure, 3-layer closure is your choice. What is important is obliteration of a dead space, no hematoma formation, no excessive cautery, and hence infection, necrosis, and weakening of the scar. I obviously will go for a multi-layer closure with the V-log because I want to take a barb suture and I want to obstruct the plane. This is very, very important is your end result. What you used was not important. What was your end result was important. Large myomas in infertile patient, associated endometriosis has to be ruled out. And then you go to surgery. For the sake of showing, I'm showing a different energy source, that is NSIL. Now, you can use even simple monopolar hook here, which I use many times. My sonologist has said very vascular space, and that's why I'm using vessel sealing to cut, because usually I don't cauterize. And if I'm not cauterizing, I will cauterize only the arterial bleed. When you give a traction, automatically many capillaries will stop it. So you can think about how you should go. What is important is not entering into the cavity in this. I think the upload speed is not allowing me to go, but that's okay. I move on to next. It got stuck. So now you don't have good energy source. Don't worry. Your Caesar itself can be a best energy source. There are, when you know that there are loops of bowel, one behind the other, the best energy source is Caesar. If you don't have too much retrograde bleeding coming from uterine wall, you don't have to bother. Otherwise, I do 1 in 100 vasopressin injection and I will take out the loops of bowel, adherent, adenomyosis, previous surgeries, multiple fibroid, always you will have. What is important is fiber by fiber dissection. Most important is, I love this sentence of mine, be aware of, I think it's okay syndrome. You cannot say on table, I think it's okay, if we'll see post-operatively, if some patient comes with peritonitis. If you have injured the bowel, you feel that ureter or the bladder, somewhere the energy source you have touched or you feel you were very close, it takes 1 minute for you to suture that. If bladder, you felt the cautery has touched, so please bury that part. Patient having fecal fistulas or urinary fistula is not. That morbidity is too much than taking out your 5 minutes and suturing the organ under question. So motivation gets you going, but discipline keeps you growing. Excellence is never being the best, it is doing your best. You need to be all the time innovative and creative. You need to be courageous. And I need to thank Endoscopy, my love, who has given us opportunity to be imaginative and creative. This unicornuate uterus, way back in 2005, 2006, we started thinking, why not to increase the cavity instead of having abortions of increasing gestation? And we received Best Paper Award for this. You just have to sit back in the night and think how differently I can work and help that patient. And then you go in. What is most important here is the energy source used, Caesar. Use very good intrauterine pressure so that you are always in the middle of the cavity. The cornal opening is your landmark. I usually love to take in unicornuate uterus when I'm doing a metroplasty, little blunt scissors. I tell my sister, keep now this blunt scissor for Asherman or for metroplasty. In such cases, don't throw them out, because just 2 millimeter coil. And when you have a very good intrauterine pressure, you will see that the pressure itself releases the fibers. Your aim here is to convert tubular cavity into triangular. The main question there that time was whether we will be able to maintain, whether the basal endometrium from this wall will generate. We gave a post-operative estrogen and progesterone. We did second look. I have shown it many times. Time doesn't permit to show me so many times, but today I have an option of stem cells. I'll come to it later. But this is how you can go. That corneal opening is telling me I can have triangular opening. Go here probably was a desired corneal opening. Don't go too much because you can cause corneal perforation and you will finish her obstetric career. Some adenomyoma protruding in the cavity. Again, your creative mind. In one decade ago, from 2000 to 2010, this was the only bipolar energy source. We had it. I used to love Versascope and Versa electrodes. The only disadvantage was there was no tissue for the histopathology. Now, if this adenomyoma, which was usually bulging with the corneal opening, you can see, I'm doing a painting in the wall. I'm demarcating anterior wall. I'm demarcating posterior wall. And I'm demarcating lateral wall. Outside this framework, I will never go so that I will not cause anterior or posterior wall perforation. So this was my lateral wall. The bubbles were another disadvantage of it, but over the period, I loved this snack. In India, we are not going. I'm waiting for the COVID pandemic because my European friends promised me to give few electrodes, and that's why I am not thrown off this Versa point. What was important is if I would have cut the adenomyoma in the center, then it would have retracted and would have given a bad wall for implantation. Today, we all know that in case of a septum, there are two controversies by the Italian group. One group saying excises and one group saying incise. But for adenomyoma, we all know that it has to be removed and you cannot. So you keep on going it. Submucous myoma, we have shown beautiful videos of Kumar. This is a 10 centimeter, only with the expertise you go, but explain the patient. We used to call that time mini hysteroscope, that is 2 mm Versascope. I'm going in to confirm that it is a type O 10 centimeter plus myoma. And this was unmarried young girl from outside India. And it was important for me to explain. So I told them, if I can't finish, my sonologist tells me to stop because even with the bipolar, you have pulmonary edema as a complication. Here, what is a trick is don't close the loop. Just withdraw your hands. You confirm with your findings. Now you know that anything inside is a myoma. Just go in, push your loop, and you take a bigger bite. Don't worry about small bites. Another important thing is don't remove those myoma. You have an open vessel channel, so don't allow too much of an intrauterine pressure. I don't want that normal saline or a ringer to get intravasited. What is important is loops of these resected pieces will keep on coming. Don't stop it. With your hydropressure, automatically they will move. The moment you stop, there will be a lot of blood and you will waste time and saline in removing those pieces. You see, I'm just resecting and those pieces are going out 10 centimeter and I'm not closing the loop. Now, what is important is take a breath. After 2-3 minutes, it's nearly non-edited and I can see the corneal opening with the beautiful. Now I need to change to right angle and I need to resect further because I saw it coming from the right lateral wall. So this is very important. Endoscopy, you keep on loving it. Loving means every night come and talk to your surgery, how you did it, and then it gives you a creative mind, a designing. Life is not about finding yourself. Life is about creating yourself. And this life we have to create as our profession, our career. Endoscopy, after entering in for a decade, I realized many more unfortunate people I can't give us justice just by my endoscopic skill. Level 4 endometriosis, extensive tuberculosis. I need to have ART with me. And then my good friend, Dr. Prakash Trivedi, I gave a call. I wish to go for it. And he said, yes, you should be. Thanks, Prakash, for motivating me, for pushing me. And this endoscopy has given me entry decision. or making my mind to go into ART in 2001, now 2 decades, and it gave me recognition as an ART consultant. I got so many fellows, so many friends across the globe. And then when I started doing ART pregnancies, I realized ART pregnancies are high risk obstetrics, high risk pregnancies. It is nothing but, and it's your not job just to give a pregnancy. Your job is to see your carry home baby rate is good. And because I had so many fellows, about 18 fellows I worked with, naturally it was much simpler to enter into high risk obstetrics as well. Endoscopy, my love to it, gave me always out of the box thinking. And I realized even if I have a ART, I still can't give a justice to few patients. For example, decreased ovarian reserve, premature ovarian failure, or the Cox cavity where I cannot. I have only third party solution, and that's where I entered into stem cells. But let me confess here the most important truth. I have not entered, or I think I would not have entered into the stem cells only as an ART consultant. I started stem cells for some other work because of some other reason in 2015 for a degenerative diseases as a regenerative medicine. But since I had such a fantastic lab and a facility and understanding, whole 2015 I've spent in learning and reading a decades of a publication which were there. I used to spend my time with my scientists and learning about the stem cells. And I need to thank my team who gave me an opportunity to come out. You know, to do the world's first record is so difficult. So endoscopy allowing me in ART, which allowed me to enter in stem cell, I could do the world record of first baby with ovarian autologous stem cell therapy in a perimenopausal year. Here, I would like to thank Dr. Madhuri Patil, the editor. During the same time, she told me to review to give her review article on stem cell, considering I'm doing the work in it. And what happened was when I was going through all the literature, which already I had been, but I realized everyone has done 40 years of lady as their highest age limit. And I was the first one. Otherwise, the first baby was born in 2015 by Egyptian people. So thanks for making me and helping me. And we are proud to present combined use of autologous. Again, this is the first time in the world. Autologous bone marrow derived stem cells with platelet rich plasma. There are many people who have done autologous bone marrow. There are many people who have done platelet rich plasma. And 2017, we realized that even there are intra-ovarian stem cells and you can stimulate them with the PRP, then why not to combine both the technology? PRP will help me to boost bone marrow derived stem cell as well as intra-ovarian. And you will find this in 2020 September issue or October issue, just published 5 days ago. It got released. This we published last year, 2017 to 19. Now, it was very important. In my pilot study, in 2 years, we took only 20 cases. If you are a pioneer in a field, you need to be choosing very carefully your inclusion and exclusion criteria. You need to be sure that patient don't have any genetic defect where it will not work. So you should be very strict. Just don't do the cases for the sake of doing it, because then the bone marrow will be labeled, the stem cells will be labeled in a bad word. This endoscopy has given me, because we started doing so much, that it gave me recognition as an author also. We published our book on endoscopies in ART and everywhere. It gave me an opportunity to enter in various organizations. I don't think as an obstetrician or a gynecologist, I would have entered so much into I would have been routine in my practice. It gave me an opportunity to work in many organizations, and it gave me recognition as a teacher. Today, all my reproductive medicine fellows from 2006. They are the leading ART consultant across the globe and even outside. And I'm tremendously proud of them. This endoscopy gave me recognition as a teacher. True leaders don't create followers, they create the leaders. And I'm so happy with all my fellows. Endoscopy also made me give a philanthropist position. This is my last slide. It gave me an opportunity how I had people with deserving or whether from any class, the lower socioeconomic class, and it was so painful to see CPR oats, tubal block, they also want to have a baby, they want to have their own gamete, but unfortunately they can't afford, and I just give Silas, Suzette, and Rajesh, all my friends and my Solo Research Foundation and 20 ART consultants who joined in this philanthropic work of Sponsor a Bird, where we sponsor the ART cycles. My heart is and always will be yours. I never can end without thanking my God, Gagangiri Maharaj, who gave me just the thing, one important message. I'm not telling you when I say you go to Pune, it is going to be easy, but I'm telling you it is going to be worth it. This is, he told me in 1991, and today I realize what I told him, what he told me. He told me, pray. And what we do daily is before we start the surgery, the entire team has to pray 1 minute, because if we are just the mediator, the creator, the performer is up above in the universe. Whichever religion you belong to, just say the God, give me the strength to do the best of the surgery. If you pray for others with a sincere heart, then you will not need to pray for yourself. I thank God for blessing me much more than I deserve. Thank you, everybody. Thank you for your time. Thank you for your patience hearing.
Sunita, congratulations for a brilliant oration. I have heard many orations in my life, but this was one of the top ones because you really put your love into it. And everything you did, every procedure you added was with love. So I think that your oration was simply brilliant. I'll always remember it, sharing it, and please save it up for me. I like to go through it again and again when I have time because it was totally brilliant. And your emotion with each case was really worth noting. And when you put your heart into your work, you get the best out of it.
Thank you,
So
Adi.
please keep up your technique of reasoning, your team, everything together, what you're doing, because that is what's giving you results. Keep up the procedure and you'll always be a good doctor wherever you go. I request, what, Sunita?
I just wanted to pass on the message to people that when patient comes to me, she has to undergo mediclaim, the anesthetics, pre-operative fitness. I don't allow after admission, all that. Follow these strict principles. If sometimes 10% of the patient may go off, allow them to go. But follow the same principles what you followed day one till today. And this is only my message to all youngsters. Do with honesty and love.
And Ruby Hall is a fabulous place. Dr. Grant is a lovely person. His family is so lovely.
I realize my love to Parsi is immense.
Yes, I'm telling you that you have got a good combination of the hospital, clinic, and everything, and your heart is in your work. So please keep it there. And I always will appreciate you because you're doing excellent work and a brilliant oration. I request my co-chairman to make their comments if they have. Krishna Kumar, I think they've left.
Krishna Kumar is muted.
Please unmute.
I can sum up our oration, me and endoscopy, a love affair, as me and Sunita's presentation, a love affair. I've always loved her presentation and today I loved it the most. Thank you, Sunita.
Excellent, Sunita. Very, very good presentation.
Thank you.
Hello.
Really liked it.
It was a marvelous oration. What I have realized is to achieve your level of skill, we need to have passion and love for endoscopy. It's really a love and affair for endoscopy. Without love, you can't do so much surgery with excellence. So congratulations and thank you so much.
Thank you. Thank you for your kind words.
So this is the oration here. We couldn't send you. I could send you the felicitation plaque, but this is with me right now. That is there with you.
Thank you.
So
Thank
I
you.
will read it. Or Atul, are you reading it? Can you see? Atul, read it.
Yes.
Yeah, the Indian Association of Gynecological Endoscopy IAGE Annual Conference President's Oration during the virtual conference Mass 2020, Marching Ahead in Safety, Skill and Knowledge, Me and Endoscopy, a Love Affair, Dr. Sunita Tandulwalkar, President IAGE 1920, on Sunday, 1st of November 2020. And Sunita, we love you.
Thank you. Thank you. And I received it. I received it. Don't worry.
Virtually.
You people are such an efficient team that it has to reach.
We have to match you also. God bless. All the best, Sunita. All the best to you.
Lovely to meet you through this virtual
Yes.
platform.
Yes.
Have worked so hard for this organization, and I'm happy that you were the chairperson. Dr. P.K. Shah was the chairperson, because the whole country, the youngsters, should know who are the pioneers of this. Thank you.
Thank you, Sunita. All the best to you. God bless.
Thank you.
Thank you. Bye.
Bye.
So, thank you, madam.
Arun, before we shift to the panel, there's been a slight
Yes.
change. We are going to have Dr. Niranjan Savant presenting his talk on fertility preservation in gynecological oncology, and then we'll go on to the panel.
Okay, sir.
Thank you. Thank you so much, Abhishek. And I would request allow me to share my screen. It's an honor.
So you can share your screen.